right. Hello, everyone. Happy Wednesday. I'm doing a few checks to see if people can see and hear us over on Facebook and over on YouTube. I'm not seeing any comments quite yet. Might be a little bit of a delay. Let me see if people can see and hear us. All right, I'm seeing this over on Facebook. If you can hear us, go ahead and leave a comment in the chat. I'm seeing this live, but want to just make sure. All right, I'm seeing the first comments come through. I know some people are trying to make sure that they're in the right place this evening. All righty. All right, looks like we are good to go on Facebook and YouTube. I know it sometimes takes a second, and I don't want to get too ahead of ourselves. So, hi, all the comments are coming in. Thank you all for joining us. So, let's go ahead and get started. My name is Alexis Johnson. I'm the social media manager here at RSDSA. I'm joined by today's guest, the one and only Dr. Philip Getson. Now, Dr. Getson's bio is amazing, so I'll read a few pieces and ensure the rest of it is in our video description. Dr. Getson is a family physician since 1976 in New Jersey. He is an internationally recognized expert in the diagnosis and treatment of CRPS and has lectured extensively on the subject at national conferences such as Pain Week and the American Association of Pain Management, as well as internationally. Dr. Getson is a board-certified thermologist and has reviewed more than 50,000 thermographic studies of the breast, thyroid, dental, and neuromuscular systems. He's a former member of RSDSA Scientific Advisory Committee. To date, he has evaluated over 2,000 patients with CRPS, and his YouTube presentations have been viewed by more than 250,000 individuals. As always, remember that while the information shared here is helpful, please consult your physician for personalized medical advice. Always want to make sure that we add in that note. Now, before we turn it over to Dr. Getson, I do have a few announcements because we have a good number of upcoming events here at RSDSA, and I want to make sure that you all are aware of what we have going on this spring. So first, we have Walk Strong taking place on Saturday, April 19th in Dallas. The event is a 3K to help raise awareness and funds for Burning Hope and RSDSA. On Saturday, June 7th, we'll host our 6th annual virtual CRPS Awareness Walk. Now, many of you know we've been hosting our virtual walk since 2020, and it's a great way for people to get out in their neighborhood and spread awareness for CRPS. Walking and running during the virtual walk is not mandatory. You can certainly participate in our virtual walk from your home, and more details on the virtual walk are on the way. And then finally, our Young Adult Weekend Retreat in Nashville is from June 27th to June 30th. Young adults with CRPS between the ages of 18 to 32 will spend the weekend with fellow warriors who fully understand what they are going through. You can find details for all of these under the events section of our Facebook page and on our website, rsds.org, and I'll also put links in the comments. All right, so enough announcements. Now on to the main event. Dr. Getson has a presentation that he's going to kick off with, and then I'll be in the comments collecting questions and responding to the community. We have a good number of questions that were already provided to us, but if you have a question, please put it in the chat and we will work to get to it before the end of the live stream. All righty, so Dr. Getson, the floor is yours.
Well, thank you very much. And let me begin by saying that I very much appreciate you, Alexis, and Sharon and the RSD Association giving me the opportunity to do this. It's been some time since I've done it. We've given a lot of lectures for the association, most of which were live, which I much prefer because I like looking at faces of people as opposed to myself in the computer screen.
No.
But as it may, there were things that need to be said, and I'm going to try and do that this evening. Uh, what I decided was that it's going to be impossible for me to discuss all the nuances of CRPS, RSD, and still answer the questions. So I've decided to take what I call a more enlightened approach to CRPS. And I think that some of the things that are going to be heard tonight probably haven't been heard before. Some of them have, some of them have not. And I think that my goal tonight is to come at this from a little bit different perspective. It has been my feeling that we have spent a very great amount of time educating the wrong people. We're educating people who have the disease. We're educating people who care for people that have the disease, and they already know a lot of this stuff. We need to educate doctors and nurses and NPs and PAs and podiatrists and dentists and physical therapists. So by doing these and having them become a part of the YouTube, I think that at least the patients and the caregivers for patients have the opportunity to reach out and say, here's a video, pay attention, look at it, and maybe you'll learn something. So I did this slide because I want to make it known that this is my presentation and not one that necessarily reflects the opinions of the RSD Association or anybody in the RSD Association, because I probably will alienate some folks tonight, and it's not my intention to do that, but I just want everyone to know where this is coming from. I want to begin by giving you a couple of significant dates in my journey, because I think it will be helpful to understand where I come from so that you understand where these opinions come from. In 1978, uh, I was in practice 2 years. I was 29 years old, and I had a patient who was a lovely older woman who had had uh, a number of heart attacks. She'd had five or six or seven. And every time she had one, the cardiologist and the internist and myself ran in, and we changed her medicines and we did the things that had to be done. And she walked out of the hospital. And then on the eighth one, she walked into the bathroom and the hospital sat down, had her eighth heart attack in the bathroom, and passed away. And it had a profound effect on me, to the degree that I went out later that day and most of the next day to a local park and yelled and screamed at nobody in particular, or at God or at the universe, saying that they weren't playing fair, that it was my job was to fix people, my job was to cure people, my job was to get people out of the hospital. And I came to the conclusion at that very young age that I wasn't going to fix everybody, that I wasn't going to cure everybody, that people were going to die. And my job was to do the best I can do. And it set a pathway for me with that particular portion of my life to understand that I was not uh, omnipotent, that I was not going to be able to do what I wanted to do in my ideal world. And it it made it it was so important to me that I thought I would bring that up this evening moving forward. Um, in 1985, I saw my first patient with then RSD. I won't go through the whole story except to say that I had no idea what was wrong with her. And it took a day and a half of internet research to come up with the answers. And once I did figure out what was wrong with her, I had no idea what to do with it. And so my journey began moving forward to see what I could learn and what I could do and what information I could offer. In 1999, I gave my first lecture to the RSD Association, which wasn't supposed to be my lecture. It was supposed to be Dr. Schwartzman's lecture, and he had to cancel at the last minute due to a family problem. And I stood up in front of a group of about 100 people, and I uttered these profound words. The first three words out of my mouth from the first lecture that I ever gave was, "I don't know." And I had 100 faces looking at me saying, you're standing up there, you're supposed to be the one telling us, and you're telling us that you don't know, but I didn't. There was so much at that point that I did not know that I began the lecture with that. In 2004, having been involved now almost 20 years, my mother stepped off a curb, stretched a ligament in her leg, and wound up with CRPS in her leg, which ultimately wound up on the other leg. And this was another part of my life that had such a profound influence because I wasn't talking to a patient in a room for 10 or 15 or 20 minutes. I was living with it at Thanksgiving and Christmas and birthdays and holidays and seeing firsthand the impact that this disease had on a loved family member. And finally, in 2014, 15 years after my first lecture, I stood up in front of a group as a keynote speaker at a pain conference. And I told the story about standing up in front of the group in 1999 and saying, I don't know. And 15 years later, and all the research and all the patients and all the time and all the effort, the first four words that I issued out of my mouth were, I still don't know. And now 11 years later, I know a lot more, but there's still so much that I and we don't know. And it's important that everyone listening tonight has to understand that there's so many uncharted courses that have to be taken and will be taken moving forward in the hopes that we can have better outcomes than we have at this point in time. So I'll start with ketamine because some of the questions had to do with ketamine. And I want to tell you that the protocols for ketamine, the very first ketamine protocols were written by Dr. Schwartzman and myself back in the early part of the 21st century and have since been moved out across the country, across the world. And I don't recognize some of them anymore because of what's been done. And I don't really want to go into that, although I will give you the protocols on the next slide because one of the questions that I was provided asked about the protocols for ketamine. But I want to make something clear. Ketamine was never intended to cure CRPS. Let me repeat that. Ketamine was never intended to cure CRPS. Ketamine in CRPS was intended to provide a degree of improvement that would allow us to look outside of the ketamine to other things and a multifaceted approach to treatment because you cannot cure disease that has no cure. So we've been very fortunate. Some people go into remission. Many people, probably 80 or 85% of those that I've treated are better as a result of ketamine. And I kind of liken ketamine and to insulin in a diabetic, and I'm not comparing them, but insulin was never meant to cure diabetes. It was meant to help control the blood sugars. Ketamine was never meant to cure CRPS. It was meant to get the symptoms under some level of control so that we could do more things to make people feel better. And it's an important point and one that you need to carry with you. One of the questions that I was given was, what about ketamine in surgery? And Dr. Schwartzman and I wrote a paper that you see at the bottom that basically says if someone has or is suspected of having CRPS, they should always use intravenous ketamine during surgery to lessen the likelihood of the spread of the disease. When I wrote the paper, my portion of the paper had 22 patients and not one of them spread the disease. In the 20 years or so since that, well, probably 15 years since we wrote the paper, I've only actually had one patient that spread the disease with intravenous ketamine. And that's an incredible statistic. So the next question is, well, what kind of surgery? And the answer is everything from extracted wisdom teeth to bunion surgery. Any kind of surgery, but especially those surgeries that involve a nerve. One of the questions that I got was, what about cataract surgery? And I've never used ketamine in cataract surgery, nor have I seen the need for it, nor have I ever seen the extension of the CRPS in cataract surgery. How much ketamine depends upon whether or not a person is ketamine naive, meaning are they getting ketamine treatments, in which case I give them whatever I give them during the ketamine treatment. And if not, we generally use anywhere from 75 to 125 milligrams of ketamine intravenously, intraoperatively. Please remember that ketamine was released as an operating room anesthetic. So anesthesiologists are very familiar with the use of the drug. It's not novel. And I tell the anesthesiologist, use whatever you want. Just make sure that one of the things that you use is ketamine in that dosage. And fortunately, I've never had an anesthesiologist argue with me. Um, I find that it is just an essential part of the anesthesia in surgery, knee surgery, back surgery, breast biopsies for sure because of the abduction of the arm. Any surgery in a patient with CRPS should have ketamine in the mixture of the anesthesia that's being given. One of the questions that I was asked is, what's my ketamine protocol? So this is my fundamental protocol. But at the bottom, I've said the most important thing is the dosing, even more important than the timing. Now, why do I say that? Because I have seen patients who have come to me from other physicians who have gotten ketamine infusions, and the mistake that's being made is they're getting the same cocktail, the same ketamine, the same adjunctive medications, day in and day out, treatment in and treatment out, and they're not the same every time. Now, if it's working, that's great. Once you find an amount of ketamine, stick to it unless something changes. I've had people where you have to decrease the dose because they lose weight. I've had people that go into flares and you have to increase the dose. I've had people with circumstances. And so the doctor who is administering the prescription for the ketamine should sit and talk to that patient and say, how was your day? How was your week? How was your month? How have you been since the last time I saw you? Because dosages change. The startup protocol, the last line of it says, and so on until reaching a proper time frame. I have patients who come every 2 weeks. I have patients who come every 4 months. There's no cookbook answer. It is not weight related. It is not gender related. It is not size related. Everybody is different, and you cannot determine the dose except by trial and error method. And that's why the consultation with the patient is so important when administering ketamine on an ongoing basis. One of the other questions that I got, which I would have handled later, but since we're talking about ketamine, it says, is it a mistake for me or other severe CRPS patients to stop getting inpatient ketamine? Inpatient ketamine is wonderful, and inpatient ketamine takes the place of the startup that you see. The problem with inpatient ketamine is finding a place where you can do it. When I started doing ketamine, we were able to do that. At this point in time, I cannot find a local hospital that will allow me to do it. But if you can get inpatient ketamine, it's a great starting point because you can increase the dosage from an average of 150, 250 milligrams a day to 900 milligrams a day. And in that particular case, more is better because you don't have to worry about the side effects if someone is going home. If you can find the intravenous ketamine hospital-based protocol, by all means look into it and then transition to the outpatient. And if at some point in time you wind up with a flare for whatever reason that the outpatient isn't controlling, move on to the inpatient again. Okay, so I'm not going to talk so much about what the signs and symptoms that exist with CRPS are. There's some things that I think are very important as I move sideways here. So I tell patients stress, change in barometric pressure, and infection are the three things that will automatically set off CRPS. Okay. Humidity is a change in barometric pressure. Cold, of course, has something to do with it. Poor diet, we're going to talk about in a few minutes. Vaccinations, there is medical literature that suggests that vaccinations can lead to Guillain-Barré syndrome and can cause irrevocable changes in CRPS patients that you cannot make better. So I tell my patients face to face, my recommendation is that you get no vaccination at all. Now, of course, people say, well, what about this one? What about that one? What about the next one? It's an individual decision. There is a risk inherent in the vaccinations, no matter what they are in CRPS patients. I strongly urge you to consider the risk-benefit ratio before you move forward with any vaccinations at all. Candida or yeast is a problem, but it's a problem that can be treated once recognized, and the treatment of Candida will minimize some of the exacerbations, some of the flare of CRPS. Budapest criteria was written by a bunch of doctors in Budapest, Hungary, in the late 1990s and amended in the early 2000s, mostly to give insurance companies an idea of when a person has CRPS. You can look it up online. It's very simple to understand. It is not etched in stone. Dr. Harden, who was the lead author, and I have had many conversations about this. It is meant as a guideline. And so if somebody says to you, you do not meet the Budapest criteria because you have to have 8 out of 10 of the criteria, but you only have 7, well, what does that mean? Okay, does it mean just because you have 7, you don't have the disease? So please understand and make sure it acts as a rebuttal to you. It is a criteria meant as a guideline, but it was really intended in part for physicians, but mostly for insurers to be able to understand how we diagnose CRPS. I love phrases and sayings, especially those that come from learned people. So Thomas Edison, back in the early 1900s, said the doctor of the future will give no medication, but will interest his patients in the care of the human frame, diet, and the cause and prevention of the disease. And I will tell you that in Western medicine, we almost never treat the cause or the prevention of the disease. That being said, I do want to mention this. I'm sure you've all seen this. We talk about opioids, and this came from the FDA. And what I really wanted to show you is in the second paragraph here, it says behavioral changes and other options. Now, I do not have any great regard for the FDA, but that being said, I think we've forgotten many doctors, myself included, have forgotten that giving people pills is not the be all end all do all. Is there a place for them? Yes. Is there a need for them? In part, yes. But it's not really meant, opioids were never meant for long-term pain relief. And despite the fact that people take them, when you really stop and think about it, it was meant for short-term relief. It was meant for post-operative pain. It was meant for other reasons, but it was never meant as a be-all, end-all until and unless at such point in time you need to add it to a complex, multifaceted modality of treatment. The reason for this statement is this. People who are listening to me who have pain in the arm, or people who are listening to me who have pain in the leg, think that there's something wrong with their arm or their leg. And to a small degree, there is. But anatomically, structurally, musculoskeletally, there's nothing wrong with your arm and leg. The problem is in the nervous system. The pain is in your brain. Now, notice I didn't say the pain is in your head. The pain is in your brain. This is a disease of the nervous system. The reason that your arm hurts, the reason that your leg hurts, is because the nervous system is shutting down in that limb. This is the reason that we have multifaceted complex regional pain syndrome. It's what people call total body disease. So if somebody comes in and says, I have a problem with my arm, yes, you have a problem with your arm, but that's not where it starts. So why are we treating arms when we should be treating brains? Hence the term organ involvement. I'm sure the people sitting out there are saying, you know, I have a problem with my bladder. I have a problem with my bowel, and we're going to talk about that more in a minute. I have a problem with my breathing, or whatever it happens to be. It's because it comes from the nervous system. The nervous system and the brain control everything. It doesn't control the arm and the leg. I mention this simply because when people say this doesn't spread, I just laugh at them. The disease, what do you mean the disease doesn't spread? The disease is in the brain, so the message from the arm to the brain gets misread and winds up in the other arm. It winds up in other areas. Why is it that bright lights bother people? Why is it that loud noises bother people? Why is it that the bass on an audio bothers other people? Why can't some people swallow? Why do women have menstrual dysfunction? And on and on and on. It's because it's a disease of the sympathetic nervous system. One of the questions was, and I know where it came from, and I thank you for that. One of the questions about gastroparesis, there's been an overwhelming upsurge of gastroparesis in my practice. Gastroparesis, by definition, is delayed emptying of solids by the stomach without any mechanical obstruction. And I want to just kind of give you a brief overview of what happens. You eat, you chew, you swallow, the food goes down the esophagus. At the bottom end of the esophagus, there's a valve. The valve opens up. The food goes into the stomach, the valve closes. The stomach is highly acidic. The acid breaks the food down into smaller particles. At the other end of the gland that we call the stomach, there's another valve. That valve opens up. The food goes in small particles, goes into the small bowel, from the small bowel to the large bowel to elimination. Unfortunately, with patients with gastroparesis, it doesn't exit. And because it doesn't exit, the food lays in the stomach and putrefies. So people with gastroparesis, their brain says, okay, it's lunchtime. They start to eat, and 2 mouthfuls later, they're full, or 2 mouthfuls later, they're throwing up because there's no room for the food because the stomach is full, because the pyloric sphincter, the back valve, does not open. I have seen more and more and more of this. I've probably seen more in the past 2 years than in the 20 years before that. And I don't have an answer for why that is. Maybe part of it's recognition. You can diagnose gastroparesis with an X-ray study called a gastric emptying study, whereby you go to a hospital, they give you food, which is understandably bad because it's hospital food. And every hour for 4 hours, they take pictures of your stomach to see how much of that food has exited your stomach. But gastroparesis, like so much else in CRPS, doesn't have to have a positive gastric emptying study. Patients come in with vomiting, excessive rapid fullness, bloating, bellies that look like they're 8 months pregnant. It's an amazing thing because ketamine works. And it really does help the gastroparesis. Getting control of the CRPS helps. Injections of Botox into that pyloric sphincter through a gastroscope helps. But I can't begin to tell you the number of people who are walking around going to gastroenterologists with these symptoms and a gastroenterologist, because they don't understand the nuances of CRPS, are missing it. I put one thing in because this is a rare condition called Derkman's disease. And that lump that I point the arrow to is a painful lipoma. For those of you who have these small lipomas that actually hurt, it is a function of the CRPS. And there is in the Southwest, I never remember if it's Colorado or New Mexico or someplace, a Derkman's Association where you can get a lot of information, a lot of expertise. I've seen it 10, 12 times, and it's usually not a solitary lesion. So I opted to put this in there because you're probably not going to hear or see this from in another place. And I wanted to make you aware of the fact that if you're one of those people that has these, it's a function of the CRPS, but there are other treatments that are available. Okay, what else? Constitutional symptoms, lethargy, fatigue, weakness, sleep disturbance, and not just sleep disturbance that comes from pain, sleep disturbance that comes from not being able to fall asleep, not being able to stay asleep, all a function of the disease. Things to consider. Attitude and outlook, we'll talk about that more. Having a support system is so important. I can't tell you the number of people who come in and say to me, my spouse, my family, my kids don't believe there's anything wrong with me because I look okay. What does that mean? I look okay. What's a diabetic look like? Diabetic looks like you and me and everybody else. Doesn't mean that you don't have a problem. Having support is great. Mobilization, moving is the first thing. Diet and lifestyle I'm going to talk about in a minute. Making good choices, where to live, where to work or not work, who to associate with, who not to associate with, these kind of choices that I'm talking, what to eat, what to drink, what to do. And this last one, those of you who may be listening or my patients know what I'm talking about when I talk about Kenny Rogers. But for those of you who don't, there isn't a week that goes by that I don't say to somebody, you know what? You got to know when to hold them, when to fold them, and when to walk away, and when to run. And the reason I say this is because if you're having a good day and you feel good, invariably you're going to do something that maybe you shouldn't do. And then tomorrow and the next day and the next day, when you spend that time in bed, okay, you look back and say, well, I probably shouldn't have done that, but I didn't know when I was going to have another good day. And if I was looking at an audience of people, half of them would be nodding their heads. But remember this, there's the kind of pain that will eventually go away and the kind of pain that won't. So those last two, my gambler analogy and making good choices go hand in hand. A little bit about food. This is a list that we came up with of food of things that you should eliminate, some of which are foods. And I've had people look at it and say, okay, well, alcohol, smoking, caffeine, my coffee. What am I supposed to do? Okay, well, I can tell you that these things will make CRPS work. And down at the worst, and down at the bottom, eggplant is the worst of the nightshades. White sugar, white flour, uh, high fructose in sodas. All of these things, okay, are going to make the disease worse. So by controlling or eliminating them, you can help yourself without therapies, without pills. The reason for the gluten being in red is the following. Uh, this came from the New England Journal of Medicine, and these are some of the 55 diseases that are caused by gluten. And the reason that fibromyalgia is in red, and I'm not going to go into the entirety of my philosophy, but my belief is that fibromyalgia is not a separate disease from CRPS. My belief is that fibromyalgia is a subsect of CRPS. And if you don't believe me, go to the National Fibromyalgia website and look at the description that the national website portrays of what fibromyalgia is. And then go look in the mirror or go to the CRPS, the RSD website and look at it, and you will see that they are virtually identical. Well, if in point of fact, gluten causes an increase in fibromyalgia, then glucose also causes an increase in CRPS. Some other lifestyle modifications. Eat organic when you can, go gluten-free, which I talked about. People don't think about the next one. You're inhaling toxic chemicals, especially Roundup, and I'm not going down that path, but you're inhaling toxic chemicals with some of the things that you do. Some of the household cleaners, shower cleansers, I mean, they're terribly irritating to the respiratory system. Well, if they're irritating the respiratory system, they're irritating to the nervous system. Okay. Refuse synthetic hormones. The body doesn't like synthetic. It doesn't like synthetic thyroids. It doesn't like synthroid. It doesn't like synthetic female or male hormones as well. Okay. Supplement your diet with vitamins and nutritional when necessary. We'll talk about that in a minute. Exercise. I don't care how encumbered you are. There's something that you can do to mobilize. There's something that you can do that goes above and beyond what you do every day. Find a healthy avenue for stress release. I put here meditation, yoga, gardening, reading, whatever it is that makes you feel good, do it. Because giving your mind a break, giving your mind a rest, taking your mind away from the day-to-day pain and not only the day-to-day pain, but the day-to-day stressors that accelerate pain. If you remember a few slides ago, I talked about what causes acceleration of pain in CRPS, and stress was the number one thing. Get away from the stress in any way you can, even if it's only temporarily. And maintain healthy relationships. If there is someone in your life who is toxic, do what you can to eliminate that relationship. if and when possible. So I want to talk to you a moment about depression. Chronic pain leads to depression. And when people come in and say, I'm not depressed, what I say to them is you get up in the morning and you feel terrible, and you spend the day feeling terrible, and you go to bed feeling terrible, knowing that you're going to wake up tomorrow morning feeling terrible. Well, I don't know. To me, that's depressing. So you go to the doctor, and the doctor says to you, you're depressed. You say, well, yeah, I am, or no, I'm not. And then you have to understand that there are two types of exogenous or endogenous depression. Exogenous depression means that you can answer the following question. I'm depressed because I'm in pain. I'm depressed because I lost my job, whatever it is. Exogenous depression. Exogenous by definition means from without, that you know why you're depressed. So why are we giving people antidepressant medicine? Why aren't we trying to fix the cause of the depression? Because it doesn't matter how much antidepressant medicine you take. You don't get better unless you fix the problem. And depression and anxiety are two sides of an axis. It's like a seesaw. If you have somebody who's depressed on one side, they're anxious on the other. It's a chicken and egg thing. Which one came first, the chicken or the egg? And most people do not take the time, most physicians do not take the time to figure out what comes first. But people in chronic pain are going to be depressed. It doesn't mean that you're psychotic or clinically depressed. It just means that circumstances have given you a degree of depression. Don't take the pills. The SSRIs do not make depression better. They make you flat. They make you less emotional. They make your mouth dry. It's not the answer. Treat the problem, not the symptom. And if you really want to find out, find somebody who understands neurotransmitters, okay, and deal with the neurotransmitters. What are neurotransmitters? These are neurotransmitters. And the list is, and there are tests that you can test neurotransmitters. You can't test them at LabCorp and Quest and conventional labs, but there are ways to test them uh, through urine and sputum and hair and things like that. And yes, it's going to cost you a couple of $100 to do it. But if you knew that you had an imbalance in neurotransmitters, doesn't it make more sense to fix the imbalance and treat the problem rather than treating the symptom? Hormones. When I do blood tests on patients, I test hormones. I test female hormones, male hormones, thyroid hormones, cortisol, because if the hormones are out of balance, the body is out of balance. And if the body is out of balance, how can you possibly hope to make yourself better? I mean, this is simple stuff that we get wrong because conventional medicine, conventional Western medicine, and I am a trained conventional medicine doctor, because if you don't look outside the limits of conventional Western medicine, you are going to miss so much that's important. Get the hormones in balance. Do it without synthetics, but get the hormones in balance. Balance the neurotransmitters and balance the vitamins, because B vitamins, okay, are depleted by stress. And going and getting a B12 shot is not an answer. You need to understand what the vitamin levels are. What is the thiamine, the riboflavin, B6? These are all vitamins. Supplement the vitamins if there's a vitamin deficiency. Most of your vitamins come from foods. And if you're eating properly and if you're digesting properly, you know, with reference back to gastroparesis and other gastrointestinal disorders, if you're eating and digested properly, then you're going to have normal B vitamin levels. But if you're not, then you're not going to have normal B vitamin levels. And then you've got to supplement it. And you want to get your supplements from a place that sells quality vitamins. You don't want to go to the local pharmacy, the local food store and get them. You want to do some research and find places that sell quality vitamins. In my world, these are basic supplements, fish oil, omega-3s, probiotics, which everybody should take every day to maximize gut health. Multivitamins, if you need them, D3, especially in women, magnesium and calcium, um, again, especially in women. And then some things that you won't find conventionally. Zypan is a digestive enzyme that comes from a company called Standard Process, which is the largest supplement company in the world. It's incredibly inexpensive and it helps with digestion. And if you really want to understand that, I'm going to give you a slide momentarily. People asked about thermography. So here's the answers to some of the questions. This is the only thermographic film study I'm going to show you. In my opinion, thermography is the only diagnostic test that will show you CRPS. Other tests, CAT scans, MRIs, X-rays, bone scans, etc., will show you what isn't wrong with you. This is the only diagnostic test out there to demonstrate sympathetic dysfunction and show you CRPS. And to me, the value of this is incredible. Number one, in medical legal instances, this is what lawyers call objective medical evidence. You can see this picture. Those of you looking at this picture understand that the circles are depicted as numbers at the bottom. And when you look at the delta average and you see 2.2, 2.0, 3.0, the human body is symmetrical. There is no reason for one limb to be more than 1 centigrade degree different from its counterpart on the opposite side, except in two instances. One, if you have a vascular problem, or two, if the message from the nerve to the blood vessels is being misread, and we call that CRPS. So as you look at the picture of the left hand, which you see on the right is cold, and is cold by a factor of up to 2.5 to 3 degrees. It is a CRPS limb. The other wonderful thing about CRPS being diagnosed by thermography is the asymmetry in temperature will sometimes show up before the symptoms do. So when this patient comes into my office and says, I have a problem with my left leg, I already know that the disease has migrated before they'd even walk in and tell me. And there's a tremendous value to knowing what you're dealing with at the earliest stages of this. So one of the questions that they asked me is, what do I want to say about thermography? And the answer is research your thermographers, find out what equipment they have, find out what experience they have, find out whether they interpret neuromuscular studies or they're just breast thermographers, because most thermographers are looking at breast studies and not looking at full body or neuromuscular studies. Do not ever have a study done by a company called Metatherm. The equipment is terrible and the training is not much better. Utilize the information to correlate with clinical exam, affirm the CRPS diagnosis, and see whether or not there are clues that it has begun its migratory path, which it does in so many instances. How do you find a thermographer? The American Academy of Thermology is the oldest formation group that will show you, that will give you the names of thermographers. You go to the website, you type in your zip code, and they will give you the names of thermographers in your geographical area. The other three are other groups of thermographic experts. Some of them are primarily chiropractic groups. Chiropractors understand the human body. Chiropractors are permitted to read neuromuscular thermograms. Doctors of Oriental medicine are. But again, it doesn't matter who the doctor is if the doctor has expertise, is certified by one of the groups, and reads neuromuscular studies. Zachary Bush is someone you should all look up. Zachary Bush is responsible for a product called Ion Biome. It is a liquid which is completely tasteless. It is an amazing, amazing product. And if you go to Zachary Bush's website, you can read way more about it than I will ever be able to tell you now, except to say that it heals leaky guts. It heals stomachs that have been abused by medication, improper eating, infection, gastroparesis, and things like that. And Zachary Bush, who is a medical doctor who has stepped outside of the realm of his training to talk about all of the problems that we're seeing with farms and the environment and atmosphere. It is worth your time to look up Zachary Bush and listen to what he has to say in his podcast. You will not be sorry that you've done that. Two other things. I put this in many of my live presentations about optimism as opposed to pessimism. You sit down and say, I'm having a terrible day. I have the worst case of this. Why did this have to happen to me? So go back and read this, okay? Realize that having it, even on your worst day, okay, you can find something to be optimistic about. You can find something to feel good about. You can, because as I'm going to show you in a minute, your attitude and your mind have so much to do with how you feel. And I'm not going to read it because this is going to be on Facebook. It's going to be on YouTube. You can go back and look at it. You can look it up. It's called the Optimist Creed. I found this in my preparation for tonight's thing. When the mind becomes so completely absorbed in perfect health that all sickness is forgotten, all the powers of mind will proceed to create health, and every trace of sickness will soon disappear. When the mind becomes so completely absorbed in higher attainments and in greater achievements that all thought of failure is forgotten, all forces of the mind will begin to work for the promotion of those attainments and achievements. The person will be gaining ground every day, and greater success will positively flow. When the mind becomes so completely absorbed in perfect health, all powers of the mind will proceed to create health. If you take nothing else from tonight's Facebook Live, take this. Your mind and your attitude are the most important factor in your improvement health-wise. I cannot stress it enough. It is so overlooked by medicine and medical professionals today. What you eat, how you deal with people, how you approach life in the universe. This is the single most important thing I want you to take away from tonight's discussion. And because I said earlier that I kind of like sayings, I have one that I use, and it's pretty simple. If it doesn't make sense, it's probably wrong. People talk about listening to their gut, and that's fine. And there's a lot to be said about that because your gut really controls so much. If it doesn't make sense, and I sit and talk to people and I say, why'd you do that? That makes sense to you? Well, no, but the doctor told me to do it. If it doesn't make sense, it's probably wrong. You can quote me. This is me, and this is the website. And there's a lot there that explains CRPS. There's a lot there that's more conventional. And I've tried in my recent discussions, whether it's Facebook Live or discussions with patients or things that I've done by Zoom, to make people understand that I started out wrong, okay, and I've spent the last few years trying to make it right, which is what I was going to call this presentation tonight. It's important to look at the bigger picture. Don't treat symptoms, treat problems, have a positive outlook, eat properly. And even if you're on a limited income, eat properly, keep moving, get out in the sun. All the things that we did, if you're my age as kids, food was food back then. We didn't have GMOs. We didn't have all this other stuff. Food is important. There was a saying that says you are what you eat. It's true. If you eat junk, you feel like junk. I'm going to stop preaching at this moment because there are some questions that have to be answered. And if we don't get them all, then maybe the association will invite me back and we'll have an addendum to this at some point in time. So, Alexis, you want to join us here? And I'm going to, if it's okay with you, I'm going to take this list that you gave me and just go through a couple of these things, and then I'll be happy to answer any one that has happened since then, if anybody's still listening.
Oh yeah, the comments are there's so many people in the comments, and like Dr. Getson just said, we are not done. We're done with the formal presentation part of tonight, but we are definitely not about to hang up. So I'm actually going to stop sharing your screen so that everyone can see both of us. And like Dr. Gesson just said, he is going to answer a few of the other questions that came through via email, via Facebook, Instagram. Y'all were sending these questions everywhere. So he's going to do that. And I'm going to continue to collect questions over on Facebook and YouTube.
I think
So
we're better off not looking at me, but okay. So,
everyone wants to see you.
so there, the first question was, is there anything new? And while I'm sure there is something new, I don't know of anything that is revolutionary new to be able to discuss. Uh, I think to preach again a little bit, the newest thing is what you heard tonight, which is step outside the box. Okay. Don't live in that box that the Western medical people have put you in. Look for different ways. Um, the second question talked about Jornavax, and to be honest with you, I don't know enough about it to be able to comment on it, and I don't want whoever submitted the question to think I was skipping over it. I just don't have an answer. But it's something I need to look up so the next time anybody asks me, I have an answer. Um, how many patients have you seen with CRPS type 2 with multiple secondary conditions? Well, I've seen over 2,000 people. I would imagine probably about 1,900 of them had secondary problems. So when I find somebody who has one limb disease who doesn't have secondary problems, I'm surprised. Um, is there any correlation between Lyme disease and CRPS and or autoimmune disorders? CRPS is an autoimmune disorder, so it would be a reasonable expectation that other autoimmune disorders would come to the forefront. The interesting thing that I found, the correlation that I found, unless you want to include fibromyalgia, which I don't, is MS, is multiple sclerosis, because I've had 6 or 7 people who've had MS and CRPS, and the amazing thing to me is that every one of them, they were all women, every one of them who went to a specialist in MS and got aggressive treatment for the MS, the CRPS went into remission. Now, 6 or 7 people does not a study make, but it's riveting and it's important enough to know. So if you have other autoimmune diseases, it's not surprising. And again, you want to get to the root of the autoimmune disease. You want to get yourself to a place of better health, because better health makes it easier to get to the individual problems, because the main problem right now is your health. It's not CRPS or whatever the other autoimmune disease is. Um, Here's a question that says, when I'm on an immunosuppressant body, my full body CRPS disappears, no matter what medication we try. So why haven't neurologists and rheumatologists and other physicians come together to co-treat CRPS this way? Again, I'm going to sidestep the question because it's not my field, and I don't want to give people misinformation. But CRPS is a disease that suppresses the immune system. And so if you're taking an immunosuppressant, short term is one thing. Long term, you're going to suppress an already suppressed immune system, and that's opening the door for horrific possibilities. So I think the reason is probably the fact that nobody wants to suppress that which is already suppressed yet further. There's a question here about CRPS and long COVID, and I have no expertise in long COVID whatsoever. So I'm going to defer that question to someone who knows more than me. Um, what's the best way to have surgery with CRPS and avoid spread? Is it possible? Yeah, it is. Okay, go back to that slide that talked about ketamine and surgery. One thing I want to mention: if somebody is having shoulder surgery and they are whether it's breast surgery or shoulder surgery, remember that you're abducting the arm. when you do that surgery. And if you have upper body CRPS, you're stretching the brachial plexus. So not only should you have ketamine, but you should not let the surgeon move your arm above a 90-degree angle. Cataract surgery was the next question, but I mentioned that ketamine protocol. I mentioned as far as the amount per hour per day, my infusions are all 4 hours. I didn't mention that in there. There are some people out there doing 1 hour infusions and 2 hour infusions and 3 hour infusions. When Dr. Schwartzman and I wrote the protocol, we based it upon the fact that, in our opinion, a 4 hour protocol was the most efficient and most efficacious. And so I stick to what we did then. And I've not had anybody give me enough information to change my mind. I have 2 patients in the entire practice, so I do this over 3 hours because I found out that they got too uncomfortable at the end of from sitting at the end of 3 hours, but the rest of the practice, I run it over 4 hours. The amount is the art of medicine. And if the doctor doesn't alter the amount, as I said earlier, then you're going to the wrong place. Is it a mistake for me or other patients to stop getting inpatient ketamine? Yeah. If you can get it and then transition to outpatient and use inpatient for flares, absolutely. Anybody who can get inpatient, by all means, start that way and use it for flares. Do you have an opinion about treating CRPS with IV lidocaine? Yes. There are patients who cannot tolerate ketamine. We give them IV lidocaine to a maximum of 400 milligrams over 4 hours. There are patients who just don't get better enough with IV ketamine. I add IV lidocaine to that up to a maximum of 400 milligrams over 4 hours, provided that they are on a heart monitor during the procedure. I would never give anybody lidocaine. I would never give anybody ketamine who wasn't on a monitor, but I certainly wouldn't give anybody ketamine and or lidocaine unless they were on heart monitors during the procedure. Please share the latest information on therapeutics that can help put CRPS into remission. Well, prayer, positive attitude, diet, lifestyle changes, all the things that I've been talking about for the last 45, 50 minutes. Family support, exercise, attitude, a doctor that will, or nurse practitioner, PA that will help you. And then being smart enough to know when to walk away once you go into remission. Because going into remission means it's up to you to keep it there for the most part. Looking at all the things that I talked about, exacerbating factors, getting it there is not the doctor's job. Getting it there is the job of you, the doctor, your family, your nutritionist, and so on, and so on, and so on. Do you think there can be remission in systemic cases? Yes, because I've seen it. This person was diagnosed in 1999 with spread. They were diagnosed in 2001 with systemic cases. It just means that it spread because the treatment wasn't rendered early enough or efficiently enough. The disease is not in the stomach, the bladder. We talked about this. The disease is in the brain. The treatment of the symptoms depends upon the symptoms. The treatment of the problem is never any different. There's a question about finding physicians with thermography. I've answered that one. What advice would you give people who've literally tried everything? CRPS went untreated for a long time. Opioids and ketamine were cut due to state restrictions. Well, there's a lot of answers, but I'll give you the quick answer. Cutting the opioids is not, it's not something I would restart. All of this last hour talked about things that you can do, and if you haven't done them, then you haven't tried everything. You could add intravenous lidocaine. You could look into IVIG, intravenous immunoglobulins. I mean, there are still things out there. There are laser treatments. You could look into acupuncture. I mean, I don't know the person. So these are all things that may fall into, we've tried everything. But, you know, there's that old saying from Yogi Berra, the former Yankee catcher, who said it's not over till it's over. And until you've literally tried everything, then there are other things to try. How does CRPS impact the digestive tract? We talked about this, and boy, trying to find a gastroenterologist that understands gastroparesis and treats it is not necessarily an easy thing. Gastroparesis is the next question. I talked about that. What are the thoughts on a carnivore diet for CRPS? I didn't know what a carnivore diet was, so I looked it up. Um, I believe in balance. I believe that all of anything, whether it's meat or anything else, is never a good idea. So I would say to you that I would not do that simply because I don't know of anybody that's ever used it and had any positive impact. And empirically, it doesn't make sense to me. And if it doesn't make sense, it's probably wrong. Um, how does someone manage nutrition if they have other health issues like an ileostomy? It is difficult to avoid the foods known to create CRPS. There's a place in New York called the Institute for Integrative Nutrition, IIN. They train nutritionists, not dietitians. They train nutritionists. I'm not sure that there are others. That just happens to be one that I know. There are nutritionists all over the country, all over the world. Um, get on the internet, find a holistic nutritionist, someone who understands that it's not about adjusting the diet like most dietitians do for diabetes and other things, and work with the nutritionist who is holistically, organically trained to come up with the right and wrong for you. It is time well spent. It is money well spent. It is something that is so important. To me, is the second most important thing beyond mental outlook. And they're out there. It's just a matter of knowing that you need to look and knowing where to look. Alexis, I've gotten through my part of the list. Your turn.
All right, I'm back. All right, so next part of Q&A. I just want to remind everyone, just in case you just joined, that yes, this is being recorded and the replay will be available on Facebook and YouTube. All right, so this is the question that I have seen the most tonight. Are you taking new patients?
Why did I know you were going to answer that question? At this moment, I am not for two reasons. Number one, we are full to the limits. Number two, despite what you and the RSD Association have put out there, I'm still working. I haven't retired yet, but I'm really kind of at the end of I turned 76 in 3 weeks. And after almost 49 years of doing this, I'm training people. I'm training a nurse practitioner right now. I can't tell you that the practice is not going to take new patients, but at this moment, no. Um, Simply because I can't do them justice and I won't give anybody a half of me.
Right. Okay. Definitely understand.
That being said, if someone is being treated and the doctor has a specific question or questions, I will always get on the phone with the doctor or a medical practitioner and offer my experience and expertise to talk to somebody if they're treating them in another part of the country or world.
Awesome. All right. So, why do you think diagnosis still takes such a long time for people with CRPS, even though medical personnel tell people that they know about CRPS, but it still takes people so long to get that diagnosis?
Couple of reasons. Number one, we don't teach it in school. And if it's even mentioned, it's a lot. Number two, it's easier to say somebody has fibromyalgia when they don't. That they have CRPS. But I think the two most important reasons are 21st century medicine is about being in a hurry. Get in, you've got 15 minutes, 12 of which you're spending with your back to the patient because you're typing on a typewriter or computer, rather. You're not looking at people. In order to make a diagnosis, you need to sit and ask questions. You need to look at medical records and see what was done and ruled out. My first visit with a patient is never less than an hour because I can't do it. You've got to ask the questions. Your mind has to be uh, geared to saying it's got to be working. What is this? And with each question and with each answer, whether it's a positive or negative answer, you're ruling something out. Anybody who knows me, anybody who's looked at my website, know that I'm a Sherlock Holmes fanatic. I'm just a freak of Sherlock Holmes. And my favorite Sherlock Holmes saying says, when you eliminate the impossible, whatever remains, however improbable, must be the answer. Well, that's what we're doing.
Mhm.
Well, this is what we should be doing. So you walk into a doctor's office and you see a medical practitioner who's got 15 minutes to make a diagnosis. It can't happen, which, by
Right.
the way, is the reason that I don't do telehealth visits on patients that I don't know, because I can't see them and I can't measure temperatures and I can't measure the diameter of their legs to see swelling and I can't see the redness. So if we're not looking at it and we're not using it at least in our armamentarium of what could be, then how are we going to make that diagnosis? Which goes back to the very first thing I said, Alexis, and what I've been saying to the association forever. We're talking to the wrong people. We need to talk to doctors and medical personnel. Okay. And that still is not going to be the answer because they're still not going to take the time to sit there and listen to people because that's not the way 21st century Western medicine is.
Well, we definitely have way more to do. And that's something that I know our team's been talking about is like making sure that we're getting this information. Of course, making sure patients can advocate for themselves, but making sure that we're getting this information to the physicians. So more to come there.
Yeah, I think that you take some of the YouTube videos that are out there, and the patients are learned enough that they know which ones are worthwhile and which ones aren't worthwhile, and give it to the doctor and say, here's the citation, go home and look at it. And if the doctor's doing their homework and they're doing their due diligence, they'll go home and look at it.
Right. And while we're talking about physicians, I'm going to say this at the end as well, but you all hopefully by now know, send us a DM on Facebook or email us at info@rsds.org to get physicians list for your state. And I will, of course, put that in the chat and say it at the end, but wanted to mention that while we were speaking about physicians. More questions are coming in. I'm trying to make sure I'm keeping up. I have my second monitor over here. You mentioned fibro, and there were a few questions that came up about fibro that I wanted to ask. Someone said, do you still believe CRPS and fibromyalgia are the same?
I do.
Okay.
I
And then,
have a rheumatologist every day.
mhm. And then do you think that they could be familial, fibro and CRPS?
A great question. I have in the last 20 years accumulated over 20 families with more than one member of the family that has CRPS. And if I took that to fiber, it probably would double. As a matter of fact, I actually at one point in time started to accumulate names of people all over the country because I said I'm going to do a research study. And then we couldn't get the funding for the study, and I didn't have the time to do the study. But absolutely 100%, this is genetic.
Mhm. All right, what else? I have some trying to be organized here. So we definitely got a few more questions about ketamine. Hopefully I didn't miss these questions or the answers, I should say. Does ketamine help people who have had CRPS for decades?
Like any other treatment, the longer that they've had it, the less positive the outcome is. But the answer is yes, I have seen it, and I have seen it in people that have CRPS 5 years, 10 years. I mean, I can't tell you decades, but certainly more than acute cases. And here's the thing: if you can facilitate ketamine, you will know within 2 weeks in the hands of the proper physician whether it's making a difference. So what do you have to lose?
Right. Someone asked about ketamine dissolves in the mouth. Is that as effective
Um, I
the regular way?
For me, oral ketamine is a bridge. Oral ketamine, oral ketamine does not work nearly as well as intravenous. And if I have a patient who cycles at 4 weeks, for example, and they have 3 good weeks and 1 bad week, I find that the oral ketamine gives them a better quality of life for that fourth week. So I will use oral ketamine that way. I do not use any intranasal ketamine because of some of the medical literature that says that it causes neurogenic bladders and interstitial cystitis and a problem that they don't already have. So I don't use any intranasal ketamine whatsoever. That's just me.
Mhm. Okay. Are there any meds that interact with ketamine in a bad way?
Um, not that I've ever come across. There are um, ways to study that, but I've never had one.
Okay. I'd say a couple more ketamine questions. And now that we're talking about ketamine, there's more popping up. If a patient's had severe depressive episodes following IV ketamine, is that treatable?
Well, ketamine is being used in this country 95% of the time to treat depression.
Hmm.
So if someone is getting depression from ketamine, which would be the opposite of what one would expect, I wouldn't use it. I would switch over to lidocaine or IVIG or something else. I would never, unless, I'm sorry, I shouldn't say that. I won't say never. It may be dose related. It may be that somebody's getting too much ketamine, so I would half it and see what happened. And if it was still causing depression at that point in time, I'd walk away from it.
Okay. Different question, but I wanted to go to this one. If someone's infusions, ketamine infusions are wearing off quickly after doing them for many years, um, is it possible for them to get better and last longer again, or is it a sign that they need to try something new?
If the dosage, again, it depends on the dosage. I mean, if somebody's getting, let's say, 100 milligrams of ketamine and he never got more than 100 milligrams, then try two.
Mhm.
Okay. But if somebody has gotten a pretty large dose and it's not working, it's wearing off, you could try supplementing it with the oral because that keeps the norketamine level in the body up. Or you could add IV lidocaine. I mean, there are things that can be done in moving things around, or you could get IVIG in between the ketamine treatments. So there's all kinds of maneuverability there. It doesn't necessarily mean it's not going to work. It just means you got to play with it a little bit.
Okay, and I'm happy you mentioned IVIG because that was a question someone asked. Do you recommend IVIG?
Yeah, the problem with IVIG is that most insurers will not pay for it. It's incredibly expensive unless you have a skin biopsy that diagnoses small fiber neuropathy. Most CRPS patients that I've seen, probably 80, 90% have small fiber neuropathy skin biopsies. And then the insurance companies will pay for it. But you've got to find somebody who will do a skin biopsy. The skin biopsy has to come back positive for small fiber neuropathy. And if that happens, it's great. People, they come out to your house, they do it in your home for the most part, and it's a wonderful adjunct to other therapies.
Okay. Have you had any patients with adverse reactions to ketamine who are also on Cymbalta or Wellbutrin? Uh-oh. What did I do?
Um, I was hoping nobody was going to ask me about Cymbalta.
There's
Um,
been a few questions about Cymbalta tonight. So,
well, okay. So the government comes along from time, this is my opinion. The government comes along from time to time and takes medicines off the market. They should have taken Cymbalta off the market years and years and years ago. It is a horrible, horrible drug. Okay, there's a lawsuit that's been going on for years against the Lilly people who make Cymbalta, and there's a reason for that. Go look it up and you'll find out. But more than that, okay, anybody who's taking Cymbalta, go look at the molecular structure of Cymbalta. You don't have to be a chemist. You just look at the benzene rings. If you look at the molecular structure of Cymbalta and you put it side by side with the molecular structure of LSD, they're virtually identical. So you can't get rid of the Cymbalta. You can't get off the drug. It is harder to get off of Cymbalta than any other drug that I've ever come across. I mean, I have a woman, I am not making this up. Cymbalta is a capsule with little tiny beads in it. Okay. This woman opens the capsule, takes one bead a week away to get off the drug, is how much trouble she's had getting it off the drug. So I just, of all the drugs that I don't like, that's number one on my list. So I've not had anybody that has had an adverse reaction of the combination of Cymbalta and ketamine simply because I think my practice has about two people that are on Cymbalta in it.
okay.
Um, I don't know what the adverse reaction is. I've never seen a bad reaction to a combination of Wellbutrin and ketamine.
And as soon as I said Cymbalta, I mean I think the chat has blown up with everyone saying it's not worked for me, do not do it, get off of it. So there's a lot of conversation here about Cymbalta. Okay. Now, I see you all. I've seen this question about 15 times. I'm not ignoring you. What is your opinion on low dose naltrexone?
I love it. I
Okay.
think the Strexone is great. First of all, it's innocuous, it's benign. It doesn't really have side effects. It has to be it has to be made by a compound pharmacist because conventional pharmacies don't carry low dose. It is a great alternative to other medicines that you don't want people on. I personally start people at 1.5 milligrams and take it up as high as 9 incrementally. Um, they will make you whatever dose you want. So if you start at 1.5 and you wind up finding, hey, 4.5 works for me, then just get them to make 4.5. There's a whole association that you can look up about LDN. There's way more literature than I know about and can talk about. But I found it's kind of an all or nothing drug. If it works for you, it's great. If you get up to 9 milligrams and it doesn't work, then it's not right for you. You got to go in a different direction.
Okay. All right. This question I've seen a few times too. What are your thoughts on medical cannabis?
It's another great option. Okay, as long as you're smart with it and you're not being frivolous and driving and doing all those things that you shouldn't do when you're taking it. I have, I am a medical marijuana prescriber in my area, so that should pretty much tell you how I feel about it.
Alrighty, I'm trying to actually find this LDN study that is at Stanford and put that in the chat. I'm doing so many things at one time over here. Sorry about that. Is there any connection between brain aneurysms and CRPS?
Not that I've ever seen, but that doesn't mean it doesn't exist. I've just not seen it.
Okay. And I know there's so many different questions. Okay, I want to tackle this one. Pregnancy and CRPS. This person just says, please address pregnancy and RSD. Didn't really go into specifics.
That's okay. I'll go into specifics. 7 women that I have calculated and collected data on, 7 women who went into complete remission at the beginning of their third pregnancy trimester, and all of whom, and those of whom breastfed after the baby was born. uh, the CRPS did not come back to the degree that it was before it went into remission. Do I believe that there's a connection between a pregnancy at its latter stages and CRPS improvement? Absolutely. I tried to get a study done one time. I called a company and I said, I want to do this study. And they said, well, when you have this, God's honest truth, when you have $1 million, we can start the study. And I kind of went, I'm sorry, we take this out of petty cash, but the bottom line is, like genetics, there's no question in my mind that the hormonal changes of pregnancy have something to do with it, although I don't know what it is.
Right. And I did put a link to a Facebook group. It is the Pregnancy with CRPS RC group. Or excuse me, that is not the exact name of it. It is oh, that is the name, Pregnancy with CRPS, but it's for current and future moms, moms to be with CRPS. So I've been sending people there for years. So definitely check that out. Um, More questions. Like I said, I'm trying to go through. There are so many questions. And so I may have to take you up on that second live stream, but I'm gonna try to get through a few more. I've seen a lot of people ask about gabapentin. Your thoughts on gabapentin?
Gabapentin is in the same category as Cymbalta.
Mm-hmm.
If anybody watches any of my videos, you will hear me say that gabapentin makes women fat and stupid. Gabapentin has become the be-all wonderful drug of the world. They're using it for everything. I personally don't like it because you have to get relatively high doses in most people to have it become effective, and the side effects outweigh the benefits. And again, that's my own personal opinion. And since nobody asked, I feel the same way about Lyrica, which is just the second generation of gabapentin.
Mm-hmm. And there were questions about Lyrica too. Another,
People listening here will realize I have an opinion on pretty much everything.
yes. Do you think ketamine infusions for CRPS will become more available? It's hard, of course, for to pay for it. It's hard as a caregiver to continue to pay, even if that's the only thing that will help. What do you think about
I
that?
think ketamine for CRPS will become more prevalent. I do. I have great hope. this current administration, who is looking to correct the chronic disease problem in this country, is going to realize that chronic pain is a chronic disease. Um, Unfortunately, I think that ketamine being more prevalent may be a two-edged sword. It's great because it's going to provide avenues for more people to get a drug that works. It's bad because it's going to allow doctors who have no idea what they're doing to practice ketamine infusion therapy and harm people. So I have some misgivings for that reason, but I do think it's going to happen, or at least I hope I do.
All right, I'm trying to go through the comments and see what I have missed. I've seen a few people ask about Savella.
Savella is a drug for God, it's just it's going right out of my head for fibro. I think I have zero patients on it because I have zero fibro patients because they're all CRPS patients. Um, Savella has helped some people with the problem. If you can get past the side effects, again, I'm by no means an expert, and I don't want to offer anybody or influence anybody into taking it or not taking it because of my lack of knowledge about that drug.
Okay. And hopefully I'm pronouncing this right. Lipomas, Lipomas. Someone just asked about that.
LIPO. Say it again.
Lipomas.
Don't know what it is.
If you ask that question, please clarify in the chat and then we can come
Oh,
back.
I'm sorry, I got it. I missed it.
I knew I was probably saying it wrong.
Wait, going back to the Durkheim slide that I had in the thing. Lipomas that are painful and multiple in presentation, okay, are probably Durkheim's disease, and they're very, very painful. If the question has to do with whether or not one can excise a lipoma that isn't painful, as long as you recognize that ketamine should be given during the procedure, I have no problem with that. But painful lipomas are Durkheim's.
Okay. And then someone else asked about peptides. Nothing specific, just talk about CRPS and peptides.
Again, I'm missing the word because of my hearing.
Oh, sorry, peptides.
No, I heard that I don't have an answer for that because
Oh,
of which I am intimately aware.
mm, okay. Let me see what else. Someone's asking about CRPS and dental implants. We do have dental guidelines on our website that I can send you all as well. I know now we're getting some specific questions about some of these medicines. I'm not 100% certain how to pronounce, so I'm trying to make sure I'm.
Trileptal, um,
Oh, okay.
trileptal is there are seven drugs in the anti-seizure category that started with Neurontin, which is gabapentin. Trileptal is one. It's gabapentin, Lyrica, and hopefully I'll remember all seven. Trileptal, Lamictal, Topamax, gabapentin, and Keppra. There's seven of them that we have used in various times uh, because for me there's only five because I don't use the two that I talked about, but they are anti-seizure drugs used for chronic pain and an off-label usage. And, you taper them up, you have to taper them down if they don't work. Side effects are side effects, and they can be helpful being given by somebody who knows what they're doing and, titrating them to a good level. It's one of those things that it's not a narcotic. So it's not an opioid, of course, not a narcotic, and it's something that can be used, it's worth trying. If somebody said to me, have a choice between trileptal and gabapentin, it's not a choice.
We're gonna do a few more, and please, yep, someone's saying secondary live stream is needed. So we're gonna do a few more here, because we've been on for about an hour and a half. Someone's saying, how do we manage our disability case when we have proof, but they just say it's not enough?
Guess depends on what the proof is.
Mm,
Okay. I mean, that's why we do thermography because it's visual proof. Um, if someone has had a thermogram done and they won't accept it, there is in the legal literature a case called thermographic diagnostic imaging versus Allstate. I'm not going to take the time now to tell people that I was in front of the Supreme Court of the state of New Jersey but it was a Supreme Court ruling in the state of New Jersey affirming the use of thermography in CRPS cases. It might help the lawyer to have that. The best way is to have objective medical evidence like thermography, objective evidence of all the things it's not with normal other studies, and someone who's a recognized expert in CRPS to testify on their behalf is what I find to be the best. And even then, sometimes you don't win, but you win more than you lose that way.
All right. What are your thoughts on scrambler therapy?
On, well, I'll be honest with you. I know all about it. I've had patients who've gone and had it. I I want to be politically correct, so I'm going to do it in this fashion. I've had approximately 10 patients that have had scrambler therapy. Of the 10 patients who had scrambler therapy, two of them had dramatically improved relief. Two of them got no benefit at all.
Mhm.
And the remainder were great as long as they were doing it. And a week or two later, all the symptoms came back. So for me, I will tell people that they can investigate it because maybe there'll be those two. And again, 9 people is not enough to make a judgment. So I'm not going to offer an opinion other than to provide you with statistics as I've seen them and let people draw their own conclusions. It's not covered by insurance. It tends to be expensive,
Mhm.
but sometimes it works.
All right. Another question. I think we may end with this one, but please keep adding them to the chat for a future stream and don't hang up quite yet. Don't hang up just yet. But this is currently in the news, and I've been seeing this. I saw it on Pain News Network. Someone was saying, have you heard of any research on GLP-1s and how they're being used to reduce inflammation in the body?
Research on what? I'm sorry.
GLP-1s.
I don't even know what it is. So I guess the answer.
Okay. So I will, and that was, I know that I've been seeing news stories about that. Like people who are taking like weight loss, well, they're medicine, like for diabetes typically, but then of course it does help with weight loss. But understand. So it sounds like you haven't heard any research. So we'll see. Maybe if we do our next live stream, there will be more research come out, and maybe we can have a better talk about it.
Sounds good to me.
All righty. So once again, I told you all not to hang up. Yes, this entire live stream was recorded, and I want you all to continue to add questions in the comments because this comment section right now on Facebook and YouTube is filled with so many gems. I'm seeing so many of you connect. So please keep adding your questions to Facebook and YouTube, and I'm going to go through and try to answer some of the questions that maybe some of you missed because I'm seeing some questions come in now that were answered at the beginning. So definitely take the time to rewatch this. I did also want to remind everyone, or this is, I guess, new policy that Facebook just started earlier this month that I'm frustrated about as a social media manager. But now moving forward, live streams on Facebook will only stay on Facebook for 30 days. So 30 days after today, the live stream will be gone. However, this live stream will be on YouTube. So definitely watch this over and over on Facebook, but it will be on YouTube after the next 30 days. It's a new policy that Facebook has started with live streams only staying on the site for 30 days. I would highly recommend, going through the comments, meeting other people who ask comments similar to questions that you have, and even copy and pasting some of these comments and, just keeping them in your own notes. But once again, this will be on Facebook for at least the next 30 days. Maybe they'll change their policy and this will stay here, but it will be on YouTube for forever. And I'm also going to download a copy to make sure that we do not lose this. So we're going to pin this to the top of our page so you all can rewatch this until our next live stream, which will be in May. More details on that will be coming soon. And then Dr. Getson, I'm also going to have to bug you for these slides because everyone's in the comments saying, hey, can I get a copy of the slides too? So may have to grab that. But as always, there are people in the questions everyone is asking about physicians. send us a message here on Facebook and let us know what state you live in. If you don't live in the US, let us know what country, and then I can try to see if we have contacts, because we do have contacts in different countries that also understand CRPS. Send us a DM or send us an email at info@rsds.org. We're in the process of updating our physicians list, making sure that, we're not sending you to physicians that have retired, etc. So we are in the process of doing that. That's one of our big projects for this year. If you need a support group, if you're looking to tell your story on the blog, you can also reach out to us via email. But we're here for all the different things you need. Our website is full of resources, and I'm sure I'm going to wake up to so many emails in the morning, but I will get back to all of you with the documents you need. But please keep sending us questions because I have a feeling that part two will definitely happen, Dr. Getson.
Okay, sounds good.
All right, everyone have a great evening and I'll see you soon.
Thank you. Have a good night.
You too. All right.